Welcome to this essential guide on understanding and managing Rh incompatibility. As a woman or a healthcare professional, it's crucial to be informed about Rh incompatibility. Today, we will explore the definition, etiology, and pathophysiology, risk factors, clinical features, differential diagnosis, investigations, and management of Rh compatibility. Rh incompatibility, also known as Rh disease, is a condition that occurs when a woman with Rh negative blood type is exposed to Rh positive blood cells, leading to the development of Rh antibodies. The amount of fetal blood necessary to produce Rh incompatibility varies. Once sensitized, it takes approximately 1 month for Rh antibodies in the maternal circulation to equilibrate in the fetal circulation. In 90% of cases, sensitization occurs during delivery. Therefore, most firstborn infants with Rh positive blood type are not affected because the short period from first exposure of Rh positive fetal erythrocytes to the birth of the infant is insufficient to produce a significant maternal IgG antibody response. The risk and severity of sensitization response increases with each subsequent pregnancy involving a fetus with Rh positive blood. Risk of sensitization depends largely upon the following 3 factors. 1. Volume of transplacental hemorrhage. 2. Extent of the maternal immune response. 3. Concurrent presence of ABO incompatibility. Factors that influence an Rh-negative pregnant female's chances of developing Rh incompatibility include the following: ectopic pregnancy, placenta previa, placental abruption, abdominal pelvic trauma, in utero fetal death, any invasive obstetric procedure, amniocentesis, lack of prenatal care, spontaneous abortion. During the course of Rh incompatibility, the fetus is primarily affected. Mildly affected infants may have little or no anemia and may exhibit only hyperbilirubinemia, secondary to the continuing hemolytic effect of Rh antibodies that have crossed the placenta. Moderately affected infants may have a combination of anemia and hyperbilirubinemia jaundice. In severe cases of fetal hyperbilirubinemia, kernicterus develops. Kernicterus is a neurologic syndrome caused by deposition of bilirubin into central nervous system tissues. A very serious life-threatening condition observed in infants affected by Rh incompatibility is erythroblastosis fetalis, which is characterized by severe hemolytic anemia and jaundice. Complications. Emergent delivery of an infant with hydrops fetalis should be as non-traumatic as possible. Obtain the following history: history of prior blood transfusion, Rh blood type of the mother, Rh blood type of the father, previous pregnancies, including spontaneous and elective abortions, previous administration of Rh-IgG ROGAM, mechanism of injury in cases of maternal trauma during pregnancy, presence of vaginal bleeding and/or amniotic discharge, previous invasive obstetric procedures such as amniocentesis, chordocentesis, chorionic villus sampling, or ectopic pregnancy. When an infant with an Rh-negative mother is delivered in the emergency department, a thorough physical examination of the infant must be performed after initial stabilization, and a neonatal clinician must be consulted immediately. Physical findings may vary from mild jaundice to extreme pallor and anemia with hydrops fetalis. Potential reasons for postpartum clinical failures include the following: failure to type the patient's blood during the ED visit, failure to administer Rh-IgG when indicated, error in typing the mother's or infant's blood, unrecognized fetal-maternal hemorrhage, inadequate Rh-IgG dosage for the volume of fetal-maternal hemorrhage. Other conditions to consider in patients with suspected Rh incompatibility include the following: ABO incompatibility, autoimmune hemolytic anemia, microangiopathic hemolytic anemia, spherocytosis, hereditary enzyme deficiencies, alpha thalassemia, chronic fetal-maternal hemorrhage, twin-twin transfusion, erythroblastosis fetalis, hydrops fetalis. Prenatal emergency care. Determination of Rh blood type is required in every pregnant female. Postnatal emergency care. Immediately after the birth of any infant with an Rh-negative mother in the ED or pre-hospital setting, examine blood from the umbilical cord of the infant for ABO blood group and Rh type, measure hematocrit and hemoglobin levels, perform a serum bilirubin analysis, obtain a blood smear, and perform a direct Coombs test. A positive direct Coombs test result confirms the diagnosis of antibody-induced hemolytic anemia, which suggests the presence of ABO or Rh incompatibility. Elevated serum bilirubin measurements, low hematocrit, and elevated reticulocyte count from the neonate can help determine if an early exchange transfusion is necessary. An emergent exchange transfusion, preferably performed in a neonatal intensive care setting with experience in this procedure, is required in infants born with erythroblastosis fetalis, hydrops fetalis, or kernicterus. Pre-hospital care. When possible, pre-hospital care personnel should direct their efforts on stabilization of the mother and infant, followed by immediate transport to a facility specializing in high-risk obstetric and neonatal care. Emergency department care, ED care of the pregnant woman with Rh-negative blood and a suspected fetal-maternal hemorrhage varies depending on the presentation of the patient and the gestational age of the fetus. If the mother has Rh-negative blood and has not been sensitized previously, administer human anti-D immune globulin, ROGAM, and refer the woman for further evaluation. If the mother has been sensitized previously, as determined by elevated level of maternal Rh antibodies, administration of Rh-IgG is of no value. In this situation, prompt referral to a center that specializes in high-risk obstetrics is warranted. When an infant with Rh incompatibility is delivered in the ED, a more aggressive approach is required, centering on respiratory and hemodynamic stabilization of the infant and determining the need for an emergent exchange transfusion and phototherapy. Stress the importance of early prenatal care to each pregnant female who presents to the ED. Early administration of Rh-IgG in conjunction with early prenatal care is the best means to prevent Rh incompatibility. Rh-IgG, first released for general use in 1968, has been remarkably successful in the prevention of Rh incompatibility. In the Rh-negative mother, the preparation is administered after a suspected fetal-maternal hemorrhage. The exact mechanism by which passive administration of Rh-IgG prevents Rh immunization is unknown. The most likely hypothesis is that the Rh immune globulin coats the surface of fetal RBCs containing Rh antigens. These exogenous antibody-antigen complexes cross the placenta before they can stimulate the maternal endogenous immune system B cells to produce IgG antibodies. Since Rh-IgG became the standard of care in the United States, the risk of Rh incompatibility has been reduced from 10 to 20% to less than 1%. Because of its short half-life, Rh-IgG routinely is administered once at 28 weeks, gestation, and again within 72 hours after birth to all Rh-negative pregnant females as a part of routine prenatal and postnatal care. The current recommendation is that every Rh-negative non-immunized woman who presents to the ED with antepartum bleeding or potential fetal-maternal hemorrhage should receive 300 milligrams of Rh-IgG IM. For every 30 milliliters of fetal whole blood exposed to maternal circulation, 300 milligrams of Rh-IgG should be administered. A lower 50 milligrams dose preparation of Rh-IgG is available and recommended for Rh-negative females who have termination of pregnancy in the first trimester when fetal-maternal hemorrhage is believed to be minimal. The results of an epidemiologic study by Pegoraro et al., which estimated the worldwide number of pregnancies involving an Rh-D-negative mother and an Rh-D-positive fetus, suggested that about 50% of women around the globe who need immunoprophylaxis do not receive it. Thank you for joining us in this educational journey on understanding Rh incompatibility. Stay informed and take proactive steps to safeguard your health.